hoping in 25 minutes you will get to hear him talk. So continuing where I left, I was asked to touch about hyperferritinemia and dengue. I have to make a couple of disclosures here. Now that I'm living and working in Bristol in UK, I don't see dengue. What little I see and hear is through my good friend, Dr. Balasubramaniam, and the work I've done is with him. There is a colleague in Vietnam, Dr. Sophie Yakub, who kindly shared some slides with me. I've acknowledged her contribution and some work we're doing in Vietnam. So some of the work is what we have done with Child's Trust Hospital, some with Priyanka Pal in Calcutta, and some with Sophie Yakub we're planning to do. But on a day-to-day basis, while I would love to see dengue, I don't see dengue where I'm working now. For those who don't know, and those who have joined from the comfortable cold climates of temperate Western Europe and North America, dengue actually causes more damage and continues to cause more damage in India, Bangladesh, Pakistan, Sub-Saharan Africa than COVID in all its glory. But one of the dangers of our excessive attention to COVID is things like TB and dengue get comfortably forgotten. Even in 2019, 2021, more children have probably died of dengue than they have of any form of COVID. It's a mosquito-borne arbovirus disease, which can kill up to 20% of those with severe dengue. Has been a huge problem, and like lots of tropical diseases, unfortunately, it has suffered from lack of attention. If only 1% of the attention of COVID was shed on dengue, then the world would have been a much better place and more children would be living to tell the story. 40% of the world's at risk of dengue fever. Most of this is in the tropical settings, and vaccines really haven't been that helpful. This is a slight courtesy wherever I mention of Sophie Yakub's. So Sophie, with whom I worked for the last couple of years, has done amazing work in Ho Chi Minh City in the Hospital for Tropical Diseases. She's based at Oxford University, where they have a 500-bed tertiary referral unit. And I thought this is much better to contextualize it through her slide of the number of admissions they see in Vietnam in this one hospital, which is anywhere from 8 to 15,000, with about 300 to 500 with severe dengue, and absolutely no therapeutic options, which most of my Indian colleagues know, apart from supportive care. Severe dengue, which is the most feared complication, which can lead to dengue hemorrhagic shock or shock syndrome, is when you have these capillary leak leading to intravascular hypovolemia. All the intensivists would well recognize it. The dropping platelet count and the coagulopathy is always a worry when it's accompanied with significant organ impairment, be that liver, heart, or the brain. My first interest came about because of what I showed to you with ferritin, and really with Dr. Balasubramaniam and Dr. Ramachandran. We looked at ferritin in a tertiary children's hospital, which is the Kanchi Kamakodi Child's Trust Hospital. What we did was very similar. We said, in a resource-limited setting where we may not have access to soluble CD25, not have access to natural killer cell function, and all the other fancy tests, let's see what we can do with just using ferritin as a biomarker. And how is this relevant to dengue will become apparent in a couple of slides. So in that 1 year period, they diagnosed 33 children with HLH, of whom about half required PICU admission, mainly if they were with respiratory distress or those who were categorized as having severe sepsis, with only 7 needing ventilatory support. The mean age was 4 to 6 months. The third of these patients had CNS symptoms. All of them had hyperferritinemia because that was a priori the way we categorized hemophagocytic syndrome. Low hemoglobin was seen in the majority, as was low platelet in 2/3. Low fibrinogen and high LDH was seen in the majority. Marrow hemophagocytosis uptake in this cohort was much higher than any other cohort, maybe because they were ability to do serial marrows or better at targeting. But this is where the relevance to the dengue comes in. There were 5 of these children where dengue associated HLH when we started looking at ferritin, 3 with EBV and other bacterial infections. And really, apparently, compared to previous years, the survival was much better when there was some targeted immunomodulation, be they steroids or immunoglobulin, or even in the outpatient cyclosporin and etoposide, which are really the mainstay of therapy in primary hemophagocytic syndrome, which you will hopefully hear from Dr. Henter. And then along with my good friend and colleague Priyanka Pal, we did this work in one outbreak of dengue in Calcutta, or Kolkata as it's now known, where over that outbreak of the 358 dengue cases, using just full blood count and simple markers such as ferritin, we thought 8 of them could have possible hemophagocytic syndrome, in whom we gave steroids, which currently isn't a WHO mandate to do in dengue syndrome, based on some really weak studies which have kind of nailed the death on steroids in dengue. It's similar to the story of steroids in Kawasaki. Both of them are based on poor studies and tend to get a bad rap. But this is work by the NIH colleagues, while ours was in a low and middle income country setting, in a low resource setting. What they're showing here is in EBV patients with HLH, in Yersinia patients, in dengue virus associated HLH, familial hemophagocytic lymphohistiocytosis, and HLH in Still's patients, there is significant uptake of the genes which are overexpressed in those with HLH. So dengue seems to share homology, even if you just look at the color patterns. It looks a lot similar in dengue and familial hemophagocytic syndrome patients, suggesting that perhaps the dengue patients who are getting the dengue hemorrhagic shock syndrome with high ferritins may have an underlying genetic predisposition, but certainly there's no argument that they are having a form of hemophagocytic syndrome or a form of cytokine storm syndrome, depending on what you call. And this ferritin level in this study certainly correlates, which I'll come back in showing more data, with how viremic they are. So the more viremic they are, the higher the dengue levels. And I'll come back to showing this data again in more, even though you're not going to be hearing Yaninge for another 20 minutes, this is Yaninge's data from Malaysia. And what they looked at is experiences of 180 patients with severe dengue, all of whom are adults. And what I'm trying to show here is if you divide the patients of these 180, those who lived, which is 141, to those who didn't unfortunately make it, which is 39, you see, let's look at ferritin. Non-survivors, the mean was 72,000 compared to survivors, which is 20,000. LDH, 6,244 in the non-survivors compared to 843. Certainly organ damage, which most of you as intensivists and who see dengue recognize that the renal failure patients tend to do much worse. And really the mortality is in the first few weeks, because the survival after day 43 was almost 80% in this Malaysian cohort. The characteristics which they identified in multivariate logistic regression was really increasing age at hospitalization in this adult study, a SOFA score, which all of you in intensive care will well recognize as one of the scores you use, particularly in adult medicine, liver enzymes in the form of aspartate aminotransferase, and peak creatinine. So the SOFA score, the AST and the creatinine were clearly associated with an increased risk of death. The higher the SOFA score, the higher the AST, and the higher the creatinine, which led Sophie, me, and Pooja, who's going to speak later on, to talk about whether we target the hyperinflammation in infection, and can we take some of this incredible momentum with immunomodulatory therapies in COVID to end the really absolutely sparse therapeutic trials that have happened in dengue, but a condition which causes significant morbidity and mortality in the tropical settings. And I go back to this paper, which although it's now 7-8 years old, is really was done in the Caribbean island of Aruba, looking at hyperferritinemia in dengue virus associated patients, and then looking at its correlation with immune activation and coagulation disturbance. And this is me trying to make the case to you that hyperferritinemia in dengue is a form of hemophagocytic syndrome or form of cytokine storm syndrome, or what you like to call it. What they did was divide these patients into those with warning signs of severe dengue, those without warning signs of severe dengue, and then look at hyperferritinemia in these cohorts. And there were no differences in the serotypes, but certainly the hyperferritinemic patients are more likely to be viremic compared to the non-hyperferritinemic patients. There was no gender differences. Hospitalization rate was much higher in the hyperferritinemic dengue patients compared to the non-hyperferritinemic dengue patients. And again, there are 3 cohorts: those with warning signs of severe dengue, those without warning signs, those with warning signs of severe dengue. And OFI stands for other febrile illnesses, because one of the common criticisms is if you start looking at ferritin in any fever, will it go up? And what is again demonstrated is in those with warning signs, there is a higher risk of ferritin, but much higher risk of ferritin fold infection. Other febrile illnesses do not have hyperferritinemia. But as you go down, you look at outpatient and hospitalized patients, you can clearly see that the ferritin elevation in hospitalized patients is much higher compared to other febrile illnesses, as well as in other forms of dengue. Higher the viral load, higher the ferritin load, and higher the ferritin fold change as well in dengue. So the more viremic you are, the more ill you are, the higher the ferritin you will have. Now, someone's asked the question, what else can we use in a hyperferritinemic dengue patient? So here I'm going to show you a series of markers which correlate with hyperferritinemia in this cohort from Aruba, which these colleagues published. So they have ferritin, the plain white box is ferritin less than 500, which is, as you know, the HLH cutoff. Ferritin more than 500 is the gray box, and the black box is other febrile illnesses. So you can see in those with hyperferritinemia, even though the bar is set a bit low, this is the dengue hyperferritinemic, is associated with a lower platelet count compared with the non-hyperferritinemic dengue patient, which is almost in the normal range. Other febrile illness, if anything, you get a high platelet count as an acute phase reactant. Similarly, you have a relative hypofibrogenemia, although this is not as prominent as the other febrile illnesses, which is why my reluctance to use hypofibrogenemia exclusively as a key marker. The transaminases, interestingly, significant elevation of AST and ALT in patients with hyperferritinemic dengue compared with non-hyperferritinemic dengue and other febrile illnesses, both of whom do not have significant elevations of AST or ALT. Soluble IL-2 receptors, if you can access them, and IL-18 levels, because this was an academic study, certainly there is elevation of soluble IL-2 receptor levels, although the IL-10 elevation doesn't really discriminate between hyperferritinemic and non-hyperferritinemic. Again, the soluble IL-2 receptor levels, as you might recall, is a key part of the diagnostic criteria of hemophagocytic syndrome. So really high transaminases, low platelet count, and high levels of soluble IL-2 receptor are all demonstrating that these patients have a hemophagocytic syndrome. Some believe the von Willebrand factor to be a marker of vascular endothelial damage, as well as the ongoing coagulopathy, and the thrombin-antithrombin complex, which is to demonstrate the coagulopathy that happens. And all of these are elevated in the hyperferritinemic dengue patients, which is the gray bar. And the same is true for the levels of decrease in thrombin, which again is a marker of coagulopathy seen in the hyperferritinemic dengue patients. And the plasminogen antiplasmin complexes, again a marker of coagulopathy, significantly elevated in the hyperferritinemic patients, while not being elevated in other febrile illness or in the normoferritinemic dengue patients. And the same for plasminogen activator 1 and D-dimer, which are all really repeated markers of coagulopathy and demonstrating that there is a form of hemophagocytic syndrome in those in whom we use ferritin as a marker of hemophagocytic syndrome. And really, all of that is fine. You may say, what is the relevance to me as a practicing pediatrician or an intensivist working in India when I see a sick child or a sick adult? And really what we show here is the severe dengue patients, as by the WHO dengue classification, are more likely to have high ferritin levels. They're more likely to have plasma leakage, more likely to present in shock, and they're more likely to have severe hemorrhagic manifestations. So really, your sick dengue patient who is presenting in shock, who may have hemorrhage, is more likely to be categorized as severe, is more likely to have high ferritin levels. And as demonstrated by Yaninge in the Malaysian cohort, those who do not survive, sadly, from dengue are the ones who have several-fold elevation. And if you cluster these patients, the cluster with the severe disease is the ones who have the highest levels of ferritin elevation. And it's the same heat map and cytokine map that they show. Again, you'll have to take my word unless you read this paper, that clearly demonstrating the homology with familial hemophagocytic syndrome and the significant elevation of some of these cytokines that they look for in those with hyperferritinemia associated with dengue infection. Randy Cron, who's joined the faculty, and several of his colleagues speculated about viral hemorrhagic fevers long before COVID hit our shows in 2015, of how certain viruses, be they Ebola or be they Marburg or Lassa or dengue, which tends to affect more populations, may represent a form of reactive secondary hemophagocytic syndrome. And again, why does it matter? Because of the reluctance of intensivists and infectious diseases pediatricians to use steroids or other immunomodulatory therapies. And these patients with dengue are usually managed only with supportive care. And Sophie kindly shared this slide where she speculates with a colleague, Laura Ravino, on the pathophysiology or the pathogenesis of severe dengue, where there is some evidence of who progresses to severe disease. There's always the prospect of antibody-dependent enhancement, which is a major limitation to developing vaccines, and that the non-neutralizing IgG might facilitate viral entry. And then you have clonal expansion of T cells with low avidity for the current serotype, with a high avidity for previous infection, which really mediates the antibody-dependent enhancement. And the failure to obtain viral control because of probably defective apoptosis, which leads to this hypercytokainemia. And the clinical manifestation of vascular leakage or capillary leak and tissue damage that most of you who treat these patients are familiar with. So where do we go? I'm plugging shamelessly a trial that Sophie is leading and I'm closely involved with, which is a trial of anakinra for dengue patients. Of course, most of you who are listening in India are going to say that anakinra isn't available. But here I'm demonstrating an example of trying to do a randomized double-blind placebo-controlled trial for dengue, and I urge you to do the same, be it for a low-cost option such as IV methylpred or oral steroids in dengue. And really, our hypothesis is IL-1 mediated pathways drive hyperinflammation and severe disease in dengue, and that using therapeutic IL-1 receptor blockade in selected patients with biomarkers which are suggestive that they will benefit from anakinra will improve these outcomes. And alongside, there will be a host of mechanistic analysis to try and identify novel mechanisms and pathways which might represent future biomarkers or even therapeutic targets. So we have a host of aims. Really, the one which most of you might be interested in is, can we improve clinical outcomes in a phase 2 RCT of anakinra in dengue patients with hyperinflammation? So how do we categorize hyperinflammation? We will categorize those with intermediate or severe dengue as those with ferritin levels of more than 2,000, about the age of 12, because this is predominantly going to be an adolescent and young adult trial. We plan to recruit 150 patients in the hospital for tropical diseases in Ho Chi Minh City with this intermediate severe type dengue and signs of hyperinflammation. And our intervention is IV anakinra 200 milligrams twice a day for 4 days versus placebo. Some of you may be aware that there is a trial of anakinra which has been published where they used plasminogen, SUPAR, serum uroplasminogen activator receptor, as a biomarker in COVID, which shows significant efficacy, what's called the Save More trial, published in Nature, which I'm not going to review. But some of our therapeutic strategy is not dissimilar to that, and looking at doing this in emergency departments and ICUs in the hospital for tropical diseases. Primary outcome for most of the intensivists will be a delta of a modified SOFA score and looking at this change in the modified SOFA score over 4 days after randomization, but with a host of secondary outcomes, all of which highly relevant to our patient population, which is a 30-day mortality, similar to the 28-day mortality, which has become kind of the key primary outcome in all the COVID trials, number of days in ICU, number of days in hospital, number of serious adverse events, and then a host of biomarker changes. And really my key message, and I'm going to be challenged on this and happy to take questions, is dengue in a small proportion of children and adults does present as a secondary hemophagocytic syndrome. There is need to consider immunomodulatory therapies. We shouldn't arbitrarily dismiss steroids and other immunomodulatory therapies because of a few poorly conducted studies which did not demonstrate efficacy. And that's more down to the nature of the study, the absence of biomarker, the absence of stratification of these patients in the studies. And my acknowledgement to Dr. Balasubramaniam and Dr. Bala Ramachandran, Child's Trust Hospital, as well as Dr. Sophie Yakub, who kindly shared some of those slides on the impact of dengue globally. I hope that gives enough time for Yaningay to sort his glitches, and I'll stop sharing and take any questions.
Thank you, Professor Ramanan. That was indeed another excellent discussion. I myself have some personal questions to you. You are advocating very strongly the option of considering immunomodulatory therapy it's, as a general pediatrician, as somebody who's interested in infectious diseases, we have two problems when it comes to choosing such medication. We have starting trouble and stopping trouble. We don't know what to start with and how to start, and then when to stop it. So I want you to tell us, see, when you talk about immunomodulation, the cheapest immunomodulation I have is dexamethasone, and the most expensive one is anakinra as of now. And in between, we also have tocilizumab. You didn't mention about it, but I don't know whether it is relevant with regard to dengue. I want you to tell me at what point of time in a child with a diagnosis of dengue, I should start considering CRS. And second question is, when do I intervene? Third question is, what do I do? What is the choice? How do I choose?
Yeah, you probably know the answer as much as I do because some of the work we did together. And I think I don't want you to take messages from anecdotes. And I think I'd urge you to try and do a trial of steroids like they've done in recovery, which is possible given the huge number of cases of dengue. As you know, most of you see more cases of dengue than you see of COVID in your children's hospitals. Shouldn't be hard to do. But if I was being forced at the pain of death to make an answer, I would say if you have very high levels of ferritin, at least in the tens of thousands, as we did in that study almost 13 years ago, then it's perfectly reasonable in a resource-limited setting to consider the use of something like IV methylprednisolone in the right context after the appropriate supportive therapy has been given. It's not, the reason I'm putting so many caveats is people will like me to say, oh, more than 10,000 I do this, less than 10,000 I don't do this. It doesn't quite work like that, but it's the context really. If you have got a severe dengue patient who is deteriorating in spite of appropriate immunomodulatory therapy, then certainly, as Yanninge has done in the Malaysian cohort and shown that there's a clear correlation between very high levels of ferritin and survival. So I think in your patients with ferritin of more than 10,000 with cytopenia who are not getting better in spite of your supportive care and other appropriate measures, then it would be appropriate to consider in the time frame where we're waiting to get evidence. I'm not recommending anakinra because that's what the trial is about. I don't think we should be giving drugs without doing the trials, but I don't think you should always wait for others to do the trials as well. You will have the patient population to do the trials yourself.
What about combination of both IVIG and steroids? We Indian pediatricians, we always want to do something to prevent infection and then give immunosuppressants. And that gives us a level of comfort. I know it's not really very scientific. High ferritin, you give both IVIG and steroids. Is that fine?
Well, these are things which make you feel good, but I don't know necessarily if they're grounded in science. IVIG and unless there's evidence, it's a very expensive option. It's in short supply, at least in the West. And I don't want to be willy-nilly recommending IVIG for all. There are putative theories where IVIG might mop up circulating antibodies working on the anti-idiotypes, but it would be better to do this in the face of some evidence rather than to do that just because it makes anyone feel comfortable.
Okay, somebody has asked, cutoff of 2,000 for dengue trial may end up treating too many moderately sick dengue with anakinra.
It's a great question, actually. And I think we did this based on, at least Sophie and I discussed this, and they did this based on what they saw in Vietnam. And I think it's a valid comment. It's one we have to be very cognizant of. But that's the value we've chosen based on the large cohort of adults with hyperferritinemia in the Vietnamese context we have seen. It might be different, but I would like to be shown some data from others showing that about 2,000 is extremely common. I haven't seen such data, but happy to be corrected.
Somebody has asked, is timing of immunomodulation important? Any suggestions with respect to dengue?
Well, first caveat is we haven't shown immunomodulation always makes it better. What I've shown you is that there are a cohort of patients who do badly, which you already know, that there is potentially a biomarker in ferritin which might predict poor outcome along with other things such as organ failure. When do you intervene? It depends on whether they are not responding to supportive care or not, and then carefully calibrating their clinical status with biomarkers. I don't think there will be a one size fits all single easy answer.
Somebody has asked a very pertinent question. Are there any risk factors for the poor general pediatrician on day 1, 2, 3, 4 to predict which of his patients is going to develop secondary HLH or MAS? Are there answers to this question?
I don't think there are, but that's what I'd urge you to try and find. I don't think you can predict that easily. There are some who do well and there are some who don't, but careful monitoring of the individual clinical status and biomarker. And I know most of these answers don't immediately address your questions, because I know, as someone who visits India regularly, as someone who works with you closely, that this is a constant clinical dilemma, that you find which dengue patient and when should we intervene and not. But I really would go back to, as we've always discussed, about calibrating the clinical status. And I think, you know, I see a host of questions in the chat in the corner of my eye. I think we can't really do genetic studies. We know we can't really in a timely fashion do soluble CD25. Most of the time we can't do a marrow mesh. So we really have to work within the constraints that most of you face there, which is you have the clinical status and you have cheap biomarkers. And how can we stratify those cheap biomarkers to help address the needs of our patient population? And preferably, I think the need of the hour is a trial of steroids in a well-constructed randomized trial, rather than look at more unaffordable, expensive options such as anakinra or doing primary HLH mutation screening, which will all be interesting but incredibly hard to achieve in the resource-constrained environments that most of you operate in.
Okay, one more question. Do you recommend doing ferritin level in all cases of dengue? If so, on what day of illness will doing ferritin early, very early, be futile? Of course, you know my strong views on this. We had already discussed, but please answer this question.
Yeah, so I don't think you should do it in everybody, but in hospitalized patients at the time of requesting a full blood count, it's not an unreasonable proposition in my mind. But you shouldn't do dengue in someone who is not hospitalized and you're not going to do blood tests anyway. But if you do, then when you do a full blood count and look at the platelets, perhaps that's a time to consider doing a ferritin. Being relatively inexpensive, I wouldn't do it for its own sake, but I would do it at the time of monitoring. Most of you will monitor the platelet count, certainly in ferritin patients, and perhaps adding it at that time may not be unreasonable, in my opinion.
Okay, in fact, in our institution, we restrict to only those with severe dengue. We don't do in all those hospitalized for dengue. Anybody who goes to ICU, anybody who has severe dengue by the WHO classification, we do ferritin. Otherwise, we don't perform, because you know, ferritin may come the next morning, by which time the child would be only on ORS. So even if it is high, we may not react.
Which is fantastic, actually. I mean, what you're doing is what's most appropriate. What I'm saying, it would give us some data on what happens in those who are moderately ill and then get better, which is what we don't have, which comes back to the question of, will we see a lot of moderates with more than 2,000? We don't know the true answer to the question, because as you rightly point out, you do what is exactly the right thing to do clinically in a resource-restrained setting, which is do it on only those who need it, which does leave us sometimes with a question which is more of academic value. Do moderate dengue patients who get better on just supportive therapy also have high ferritins or not? Of course, the best way to address that question would be to do it prospectively in a control setting, which doesn't cost the patient.
If time permits, one more interesting question is dengue HLH. Sorry, in dengue HLH patients, is there a need to screen for genetic mutations?
Not in my opinion, but it depends on your access, your ability, and you know, in a resource-restricted setting, I don't think I would do that.